with that one, I guess. All right, I'm going to try to pull up Northern Virginia. There we go. I can see you guys fine. Can you hear and see me okay, Northern Virginia? A little less chaos on the roads this week versus last week and over the weekend. Yes. All right, things are mostly getting back to normal as they typically do. All right. We're going to go ahead and get started this morning. We have essentially from now till 9:50 to talk about restrictive lung diseases. I honestly think in terms of the grand scheme of things and how much we will encounter patients in our practice with restrictive lung disease, probably more than we need. You'll notice that there are going to be a lot of slides that I am going to kind of work pretty quickly through. I want to point out that you have noticed, if you've looked ahead in the slides or read the readings or other readings on restrictive lung diseases, there's like this laundry list of all of these different disorders that can be associated with restrictive lung disease. Our focus is on that pulmonary component. You will not walk away. It is not our objective today for you to walk away from this lecture with the ability to go out tomorrow and write a comprehensive care plan for the patient with sarcoidosis, patient with any of these other conditions. We can't get into the weeds on all of those things. So I'm trying to pull out some of the key things about those. But again, some of these you'll touch on later. Others you may, if you're faced with a patient who has that disorder, there's usually a lot more to that. Restrictive lung disease may be the least of their worries when it comes to that overall disorder. So it's hard to put all that into perspective. But again, I just want to point out we are going to run through these fairly quickly. Many of them, it's not meant to be a comprehensive lecture on 29 different restrictive lung disease and disorders. And then again, some of these, because of the uncommon nature of those diseases, because the restrictive disease component may or may not be hugely significant, for a variety of reasons, we're going to just give them just a very short treatment and lecture today. They're bigger fish for us to fry together in the time that we have face-to-face. So I want to try to get to some of those things. So we'll move pretty quickly. Please know that that doesn't mean that, I've put things on a slide for a reason. I've tried to pull out some of the key points about that. The focus in on the test from this section is really on that restrictive lung disease component. What is it about this disease that makes this person at risk for a restrictive lung disease pattern? Trying to focus there, not on all the other stuff. But sometimes, like whether or not the patient is, you can move to the front if you want. It's okay. It actually kind of helps me, like, how your feng shui is off, like with you not in the front, I'm like, oh, something's not right up here. Like my space isn't right. I got to figure it out. Oh, kind of not right. Okay.
I'm sorry.
It's okay. All right, so we're going to go ahead and dive in here again. We're going to move fairly quickly. I'll spend a little bit more time on things that are specific to the anesthetic environment. A few things are complications of anesthesia. I want to spend a little time on those, and then we'll kind of run through the others, and then whether or not we break in the middle of this will just depend on how quickly we're getting through here. I will end at 10 till, so let's motor for that. Again, tons of different disorders. These are generally categorized. Now I'm going to go predominantly with the scheme that's in Nagelhout and Plouse, because that's your required reading. It's the one, not necessarily the overall best, but it does at least try to get some comprehensive treatment of each of these things. Another good reference, especially if you're looking toward making a care plan, especially for things that might be slightly more uncommon. We can't require every textbook as a required text for the course. So I just want to pen on a couple of other places I've peeked at in terms of picking out some of these things. The anesthesia and coexisting disease, this will cover somewhat more common disorders, a few of the more rare ones that we really don't speak to in Nagelhout are in here. So this is a reasonably good source as well. I've definitely peeked at that for some of the information here. I've listed the names of these texts on the reference slide. The other, in terms of making care plans for specific conditions, and it does run through it very much like a care plan, both of these available to you online through the VCU library, both of them on the Clinical Key database. This is the Fleischer and Roizen Essence of Anesthesia Practice, and it has a variety of sections, but one of them is by disease process, and it will, again, kind of walk you through more comprehensively the important care planning pieces for these various conditions. So again, I've consulted these. If you're looking for more information about some of these disorders, there's another that's on Clinical Key, which is called, I think, Anesthesia and Uncommon Diseases for very rare conditions. One of the big things is to recognize with a disease condition, if it has been associated with restrictive lung disease, bing, 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 that should just flash in your mind. So I'm just trying to put a few names together here today. All right. I am going to, again, mostly use the organizational structure that they use. We're going to speak to each of these issues, the objectives that are listed on Blackboard. I'm going to use, let me skip ahead here to the classifications that Nagelhout uses. In particular, they'll go through the acute and chronic. The categorization scheme most often uses chronic intrinsic, acute intrinsic, and then extrinsic. And in the Stolting text, they basically do it that way as well. Chronic and acute intrinsic disorders, and then all the others. Neuromuscular diseases, they define that quite a bit more broadly. Neuromuscular diseases and chest wall deformities, etc. So that's kind of really the three categories that we'll talk about. I will admit I'm not going to go through them in the order that we're talking about in the text, because it just made more sense to me. There's a method to why I'm going through it this way, though it may or may not be clear. I think our perspective is sometimes different. The first thing we have to talk about for all of the disorders, whether it's acute or chronic, intrinsic, extrinsic, etc., what is the common theme? Why do those get the stuff moving around over here? My monitors are falling over here. I've got a view of you guys on the side, and it's just kind of falling apart over here. Oh, good Lord. Okay. Well, we're going to leave that propped right there. I'm not going to blow on it or touch it. My monitor has just, the drywall screws have just pulled out of the wall. It's like teetering over. And I'm thinking that I better just leave it where it is and not touch it. But at any rate, that's the distraction here. All right, so what is the common theme to all these? With the obstructive diseases that we've already talked about, if you had to look at inspiration versus exhalation, which is the primary dysfunction, it was on the expiratory side. In the restrictive lung disorders, and that's kind of a pretty good mental model to think about, these are problems more with the inspiratory side. Overall, decreased compliance of the pulmonary system, whether that's because of, compliance can be separated into really those two components, compliance of the lung and the lung tissue and the surrounding tissues, the pleura, or it can be sort of that external of the chest wall compliance. But fundamentally, these are things that represent a decrease in compliance. So it's difficult to get that air in. All of the sequelae that go along with that. They are essentially marked by situations where the person has decreased lung volumes, very, very severe disease. Total lung capacity may get as low as the 5th percentile. They do typically associate with a normal or an elevated FEV1 to forced vital capacity ratio. So for the volumes that the person's getting out, there's no limitation in how quickly they can get that breath out. It's not predominantly, it may be a low FEV1, but we're talking about low volumes. Remember, if you blow up a big balloon, there's more tension in that. The air is going to come out faster, so the FEV1 might be slower, but for the forced vital capacity, we're talking about the ratio of those two parameters is not upset. Does that make sense? So overall, both of them may be low, but the ratio is maintained or may even be elevated. So they may have a very easy time relatively to get the air out. It's that getting the air in part that's the issue for them. It's difficult to expand the lungs due to the underlying pathophysiology. Again, we'll talk about these. We'll try to categorize them as acute versus chronic, intrinsic versus extrinsic. It does kind of help you to some degree to understand what's going on there, but these are not hard and fast and widely recognized by all sources. You'll see some variability in the way that they're categorized. We'll stick with Nagelhout's classifications. And this is the order in which I'm going to go through these today. Again, there's a reason I'm doing that. I can lump a lot more of the intrinsic disorders together. I'm going to get into the chronic ones first because it is easier to lump those together. And then as we progress through this little bullet point outline, we have to kind of basically talk a little bit about the anesthetic implications of specific disorders versus lumping them all into one big piece. So I've tried to put together all the ones at the beginning that we can kind of lump, if we will, and lump all of the major anesthetic implications and interventions into one big category. That's the rationale for that. All right, so again, kind of starting with the chronic intrinsic lung disease. This is often referred to also as the interstitial lung disease, chronic intrinsic. These are diseases that are characterized by pulmonary fibrosis, maybe of very variability in terms of what that fibrosis looks like, particularly at a cellular level. How does that fibrosis manifest? There are often histological changes that are characteristic of that particular disorder. Some of the ones that are commonly lumped into this category as associated with pulmonary fibrosis I have listed here, and most of these we will talk about specifically when I speak to the cytotoxic and non-cytotoxic drug exposure, oxygen toxicity, and then we'll talk about sarcoidosis. But again, recognizing that the others here are associated with this category with pulmonary fibrosis. And it's important to note here in terms of the anesthetic implications that these are disorders that are very often associated with pulmonary hypertension. You can see that with any of the restrictive disorders, but these in particular are often associated with this. What about drug-induced pulmonary disease? We cannot talk about all of the drugs that are associated with pulmonary fibrosis as a side effect. You'll see it is listed in many drugs as a very, very rare complication. You may be the unlucky 1 in a million who gets pulmonary fibrosis from a particular drug. The ones that are more commonly associated that we will speak to, and we really don't have a solid understanding. It likely varies dependent upon the drug and the circumstances. Certainly some folks are more at risk for this complication versus other due to their underlying condition. But we know that we can recognize that these tend to be effects that are either direct, the toxic effect of that drug on the cells when it is absorbed into that area, and then the indirect effect, or the secondary. There's that initial response. There's, that drug is into that compartment. It's absorbed by the lung tissue. You get that direct effect, and then what does that do? It stimulates the body to say, what the hell? And it will mobilize the body's resources, the inflammatory or immune processes, to try to address that issue locally. The body tries to undo some of these effects. And these are typically categorized as non-cytotoxic injury and cytotoxic injury. They look somewhat different. The non-cytotoxic injury, which often the prototype for this discussion is amiodarone. I can tell you that this is a side effect that is common enough that is one of the most common reasons that folks present to the PFT lab for chronic pulmonary function testing, and they'll be followed on PFTs on a regular basis when put on chronic amiodarone therapy. So it's not particularly rare. I mean, it's a definite known complication, much like many drugs. If you're on that drug, they will follow serial LFTs. So it is something that happens enough that we will see that. Certainly not something that we run into in the perioperative period to a large extent. So I'm not going to spend a lot of time talking about this. I mean, what are the specific abnormalities? They're really looking at on PFTs. What is the primary change that they're looking at? This is the LCO, the diffusion capacity of the lung. That's one of the things that they're really zoned in on when they're trying to assess these patients and assess the impact of being on amiodarone chronically. The other effects and what it looks like, it can look a lot like ARDS. Again, makes a good sense that this is an interstitial lung disease. But this is something that, again, somebody who's on chronic amiodarone therapy, we're going to be watching them for this. I honestly don't know if I've ever seen a patient with amiodarone-induced restrictive lung disease in the perioperative period, but for what it's worth. The other thing to note about amiodarone, what is the half-life of that drug? Ridiculously long. It's a really long half-life, so that's important to note. So does the person have to be on amiodarone any longer? No, this could have been someone who was taken off amiodarone weeks ago. If they present with this new onset of pulmonary symptoms while on that therapy, they will take them off the drug, try to substitute with other drugs in its place. The process is not necessarily fully reversible. You do see some fibrotic changes that are not fully reversible. And then, again, it can persist for weeks afterwards. If you look at the half-life of the drug, and particularly if someone's on a therapeutic level of that can be a long-term issue that we need to worry about. The prototype for cytotoxic drug-induced pulmonary fibrosis or pulmonary intrinsic lung disease is bleomycin. This is, of course, in subsets of patients who are receiving chemotherapy for cancer. So again, this is one of those situations where, yes, if a person's on bleomycin for their cancer, they are going to be followed chronically, watched for this complication. Up to 10 to 40% of patients who are on bleomycin, particularly in the higher doses, will develop this. So it is something that is a major part of our care plan for patients with cancer. What drugs are you on? Most of us are not. How many feel a little bit at a loss for having a good grasp on all the drugs that might be utilized in modern chemotherapy regimens? Whew, my head swims. I've never worked in hem-onc. But in terms of patients who are being treated for cancer, they're currently on chemotherapy. One of the things in our anesthetic pre-op will be, are you taking bleomycin? And if so, then we'll want to look for any clinical evidence that this person may have had some pulmonary toxicity as a result of being on that drug. Again, some of the, how many patients with cancer have low-grade fever, fatigue, malaise? I mean, those components may be very difficult to parse out. They can present with acute non-cardiogenic pulmonary edema, some other more acute, appearances to them, but you'll typically see the folks that, just have an increase in dyspnea or pulmonary symptoms, hyperpnea, tachypnea. one of the important things to remember as well is even if they're not actively having symptoms, let's say this is a person who presents to the operating room and they have been on bleomycin, particularly pretty moderate to high doses of that. They have no evidence of pulmonary disease right now. Great, we're good to go, right? No, the bottom line here is an anesthetic implication of that. They are at increased risk. We're going to talk about hyperoxygenation and the risk of oxygen toxicity. These patients are particularly susceptible to that, so that's important for you to know, and it does dramatically impact our anesthetic plan of care. Again, we're not going to spend a lot of time on autoimmune disorders and all of the variations of that may cause pulmonary chronic intrinsic restrictive lung pattern. Just a little bit, a few tidbits about sarcoidosis, and one of the things that I've mentioned here is that these patients tend to be on steroids. These folks will have widespread granulomatosis. They have these granulomas that form. The pulmonary fibrosis certainly can be, this is often one of their major symptoms of this disorder, one of the things that is most life-altering for them. So pulmonary fibrosis is a major component of this, but it's often not isolated. They may have predominantly pulmonary fibrosis and the symptoms associated with that, restrictive lung pattern, decreased lung compliance, etc., all of the signs and symptoms that go along with that. But you also have to think about airway issues. These granulomas may be more diffuse and cause sort of this, diffuse fibrotic changes in the lung tissue, but it may also cause granulomas in the airway. So you can get sort of more solid masses, if you will. It can be a very ugly disorder for the folks who have very severe cases of this. And this is fibrosis of multi-system. They can have essentially all organs affected, cardiovascular, the cardiac conduction system. They can have vascular changes. They can have liver, renal involvement, etc. These are not purely isolated, but unfortunately, again, the pulmonary system may be the most heavily affected. I mentioned the steroids here again because I can't not mention that. If steroids are a mainstay of therapy, whether they're on it currently or they have been on it in the recent past, supplementation may be in order. Again, I mentioned we're going to talk a little bit more about oxygen toxicity in and of itself in patients who have specific risk factors. We need to think about this as one mechanism that can put them at risk for a pulmonary restrictive lung disease situation. All right, what are the patients who are most at risk? All patients? We don't willy-nilly give high FiO2 to any patient, right? We're going to talk a little bit more, hopefully a little bit today, but in general, we're going to talk about management of ventilatory strategies in the perioperative period. We should not be willy-nilly giving oxygen at 100% to all of our patients in the perioperative period just because. How many of you have already seen that in your time in the operating room? Patients being left on 100% for the entire case. There are some sites that really have only oxygen and nitrous. That's it. That's all they have on their machine. So in order to give lower than 100% FiO2, they have to give nitrous or they give 100% of FiO2. So those are sites where you might be seeing that more often. But there are untoward effects of that. We've talked a lot about that already in terms of predisposing patients to atelectasis. We also have to think about oxygen toxicity, and it's but one of many reasons why we should not be giving willy-nilly without thinking about it. It's a drug, folks. We have to think about why we're giving 100% FiO2. What are the most susceptible patients to this particular badness that comes from increased FiO2 without any good reason to have that? Very old patients, they're friendly to the folks who have had prolonged exposure. They've been on high oxygen levels for a long period of time. Obviously, who are the patients that present to us that have been on oxygen therapy for a long period of time, particularly high FiO2? These are patients who are in the units. I mean, certainly COPD patients who are chronically on oxygen therapy and so forth. But these are, the patients we're talking prolonged exposure often are those that are already in the unit. They're on really high FiO2 to begin with. So I want to be clear, I'm not advocating you just turn down to 28% FiO2 for that. But we just have to think about it. We're always trying to minimize the amount of FiO2 we need to keep them on in order to maintain a minimum level of oxygenation. What's the target? Let's stay just above that. We don't need to be giving it. If our target's 94, we don't need to be giving higher oxygen levels till they get up to 98. The folks on chemotherapy agents I've already mentioned, and those who, of course, had radiation therapy. So those are the highest risk folks. Certainly we know in the neonate we're going to largely stay away from, I stay as far away from neonates and pediatrics at this point in your didactic phase as I can, but those certainly are patients that we worry a lot about, high FiO2. Why is this a problem? Excessive production of oxygen-free radicals. I think you guys are well familiar with those sort of sequelae that occur. What does this look like? One of the surprising things about this is, I think intuitively we imagine, because we give oxygen so freely in the hospital setting, that this is something that would take really, really, really high exposure or very, very prolonged, greater than 24, 48 hours more on 100% FiO2, and that's not the case. You may see manifestations of this very early, I think very early, within 6 hours of exposure. What does it look like if the patient's able to tell you some of these symptoms? Chest pain, you may see tachypnea, you may get a non-productive cough. That makes sense to me because, again, oxygen can depress your mucociliary function, so you may see someone who gets sort of an irritant, stimulates the irritant receptors. By 24 hours, whoa, you can start to see things like paresthesias, someone who's anorexic, nausea, they have a headache. Probably in patients who require high FiO2 in the ICUs, you can imagine this certainly contributes to the general badness you feel when you're in an intensive care unit setting. Some of the physiologic changes that we see in terms of why do we consider this and why are we talking about it today versus other days, again, decreased pulmonary compliance. We can see an impaired diffusion capacity, we can see an increased AA gradient, et cetera. And again, decreased mucus velocity we've already kind of talked about. How do we prevent this? Certainly prevention is key. We've mentioned a couple of these things. What are some of the strategies that we can utilize to minimize the amount of FiO2? We will talk a lot about alveolar recruitment maneuvers, PEEP, sort of an open lung strategy, if you will. So these are strategies that in the absence of the high FiO2s, if we religiously employ some of these measures, use adequate levels of PEEP, not just a little PEEP, because that's what we always turn on. Use an adequate level of PEEP for this patient. We may be able to get them down and off of some of that. And then, of course, someone who has developed these pathophysiologic changes associated with this, corticosteroids are an appropriate therapy in that situation. All right. So we talked about the chronic intrinsic. I'm going to move to another category before I really get into sort of the anesthetic care plan. And you're going to notice in just a second, I don't want to confuse folks about this. We're going to talk about a few of these, and then we're going to talk about anesthetic management, and then we'll parse out some of the others. The reason for pulling out some of the others that technically fall into this big lump category of extrinsic or the chest wall and other disorders is because there are some really specific things about those that we need to talk about. They're somewhat different. They're oddballs, if you will. So I'm trying to lump those that we can somewhat talk about here. But again, we're going to talk about a few of these now, and then we'll get to some of those in a minute. There's going to be some confusing flow, I think, for a second. We're going to talk about disorders of the chest wall and pleura. We're not largely going to speak to a lot of the neuromuscular disorders, and you'll also see, especially in the pathophysiology text that I've referenced, they will lump into this category as well mediastinal masses. We have an entire series of lectures. We have a lecture on bronchoscopy, mediastinoscopy, which will cover the mediastinal masses, and then those patients are often candidates. The most common procedures we will see them for would be the mediastinoscopy or thoracic surgery, thorax surgery, not necessarily a VATS, but someone we may do an open thoracotomy for and get to the mediastinal mass. So we're going to lump that one particular subset of these patients into, they got a lot of bigger fish to fry than just the restrictive component of that disorder. Very specific care plan for patients with a mediastinal mass. Okay. How often will we encounter patients with obesity? And I just want to point out here, we're not putting pregnancy right up next to obesity because pregnant women are obese. Let's just say for the record, that's not obesity. That is a decreased compliance because of baby. I'm not owning that piece. But at any rate, we deal with a lot of patients who are obese, and the sort of restrictive component, the pulmonary impact of that condition can be huge for us. We know that, and we're not going to talk a lot about obstructive sleep apnea and all of the sequelae that go along with that, but just in terms of ventilating patients who are very morbidly obese, the restrictive component, we can have a lot of trouble getting air into these patients because their lungs, what's going on there? We have all this extra mass and physical stuff around the chest wall, so they have decreased pulmonary compliance by virtue of the fact that it's restricted. They have a very, very large belly. Put a very, very obese person, particularly one, you can have favorable distribution of your adiposity, junk in the trunk, junk in the basement. That's all pretty helpful for us. That doesn't really have as much of an impact. But those people who have unfavorable disposition of their adipose tissue, what do we know about those central deposits of adipose tissue? Certainly most affected by this situation. If you have a very large abdomen and your obesity, where do you put your extra, all those adipose tissue cells, where's that adipose tissue going mostly? If it's between your hips and your shoulders, that's a big issue for us. If it's hips and above in general, it can be big deals for us, whether that's a massive airway. Are you a 6-chin person, or is this not so bad on the airway? You may have a very obese person who no airway difficulty at all. So we're talking about those subset of obese patients who happen to put it in an area where it is a lot around the chest wall. They have a very large abdomen. You take that person, put them in stirrups, where you're now pushing the abdomen up and into the chest wall and shoving the diaphragm up under the chest. Clearly, that's the subset of obese patients who we need to worry about and who do largely we need to employ our, restrictive lung disease hat. What are the measures that we can do to address this and most effectively mechanically ventilate this person under anesthesia? What does this look like? The person who's chronically, got a restrictive pattern as they're walking around. They may have very shallow breathing. Again, there's a bigger issue with this. They may have shallow breathing. You might think that would be associated with hypocarbia, but there's sort of a bigger picture of that. So it's unusual for them to present the chronic situation. What does the body do in response to tachypnea? We compensate, right? So you may not have someone who actually presents as hypocapnic. They will often be hypercarbic. Again, just speaking to treatment and stuff, obviously we can't fix their obesity in the short term. Some of the things to think about with these folks as well. This is more related to obstructive sleep apnea, but this may be a person who's chronically requiring CPAP to maintain them. So not a huge issue there. In terms of the anesthetic management, I wanted to parse out a couple of things in terms of the obese patient. Again, we're going to get into the general care plan for the patient with restrictive lung disease, but a couple of things in particular that we have to think about. IE ratio. They breathe fast all the time. They get used to breathing fast. That's sort of what their neural control is set at. We'll adjust our IE ratio. This goes along a lot with the general adjustments that we might make in the IE ratio for a patient who has restrictive lung disease. Are we going to probably be more likely to increase or decrease the IE ratio? We're going to raise the top number. So here's how respiratory therapists talk about this. We're going to adjust the I time. We're going to lengthen or shorten the I time. Lengthen the I time. We're having trouble getting in, so we're going to lengthen the I time. That's probably the more correct way to say it, but for whatever reason in the anesthesia literature, maybe my theory on this, I'm going to digress for a second, my theory on this is because what do we dial in on our vents? If you're a respiratory therapist and you're using the vents that they use in the ICU ventilators and OR ventilators, totally different animals. There are several reasons why they have to be totally different, but a major component of that is that we often use these as our anesthetic delivery system. We can use the modes and the particular features and the functionality the way that we do because we have generally patients who are under general anesthesia with muscle relaxants on board, not taking breaths at all. Or we let them manually ventilate. That's really what we use the mechanical ventilation for. So what do we have? What's the dial on the front of the machine? We're going to look at these more carefully. It's the IE ratio. For whatever reason, that's what we were using time-triggered, time-cycled vent modes. And in that setting, you could talk about IE ratio because the breath-to-breath interval is uniform. It just keeps giving the breaths, So you can talk about IE ratio because the I times are not variable. The distance between breaths is uniform versus in the patient who's triggering their own vent, that may not be a regular rate. So because this is what's on the dial, and we can do that because it makes sense for our particular ventilators and most of the patients that we will ventilate, we have IE ratio on the front of our vent. So that's what we talk about, is adjusting the IE ratio versus respiratory therapists who, again, are most often working with assisted modes, patient-triggered modes. So in those situations, it doesn't make sense at all to talk about an IE ratio because that's not fixed. It's more likely for them to talk about I time. We have to think about that if we go from a controlled mechanical ventilation mode in the perioperative period to, if you have the capability to do that on your vent, which very few of them do in some settings, if you go to an assisted mode, then you really need to get largely away from talking about IE ratio. But most of the patients that we're talking about, if we're doing a laparoscopic case in a very obese person, big belly surgery, etc., these are situations where we're talking about controlled mechanical ventilation. We fully control it, time triggered, time cycled, set IE ratio, and that's why we talk about it this way. It's not because we don't get the concept of I time. We get that. It's just, what do you dial? All right, so we would increase the ratio. There's a lot of misconception about that. Raise the top number, give them longer to breathe in. Getting air out, not such a big deal, right? They don't have a obstructive disease pattern, we hope. They don't have a mixed pattern. So once you give them that extra time to get the air in, getting it out is not so big of a deal. We don't have largely a problem with that. Here's what becomes a really big issue: maintaining peak inspiratory pressures. We try to get, this is not the ideal situation. These are the situation where we have this person who has morbid obesity, have a lot of stuff there. I mean, ideally, where would we like our plateau pressures? We'd like them lower than this, right? But these are often about as reasonable as you can get in terms of your ventilatory parameters for some of these patients. The lower the better. If we can keep the peak inspiratory pressure lower than 35, that's great. But these are pretty reasonable initial goals in terms of some of those parameters for the mechanical ventilation of the obese person. And that's really at baseline for someone with adiposity distributed where it would be for this person we're concerned about restrictive lung disease for. Does that make sense? When I start talking about anesthesia vents, folks often shut down. So if I've bypassed you on that, write down a question. We're going to get more into that, perhaps some of that today. All right, we're going to talk a little bit about the skeletal disorders. Have you guys heard about these pectus deformities? They come in variations. It's pretty easy to see why a person who has one of the pectus deformities would have a restrictive lung disease pattern. The chest wall isn't configured sort of in a standard way. It's often caved in a fixed position there, so we're not able to get breaths in as quickly and easy as we might like to. We're not going to talk a lot about kyphosis, but we will talk more about scoliosis. Obviously, there are people who have predominant kyphosis and then folks with predominant scoliosis, but these will often go together. So skeletal, spinal deformities can be a really big deal. But these patients, especially those with predominant kyphosis, not as big of a complication for us in terms of managing their ventilatory status. Scoliosis can be a big thing, and I want you to remember, we'll talk about this in the summer. Scoliosis is complex because it isn't just a lateral deformity. We can make some predictions about where the spine and structures underneath might be if it was just lateral, but this is a 3D deformity, folks. So we'll see lateral deformities, we'll see rotational deformities, and that's what makes it complex. Patients who have very severe, this is pretty significant scoliosis, pretty obvious to see. These are the patients that are going to be considered to have restrictive lung disease. I have scoliosis. Do I have problems with restrictive lung disease? Not so much. I do have a lot of issues with regional anesthesia. So we'll talk about that in the summer as we get to regional anesthesia. It can be a huge issue because we're working in the lumbar spine. Just talking about the pulmonary system, these are the patients who have very, very severe disease. But we can see it. I mean, it kind of depends on their particular. This is a unique situation with each of these folks. You may see some folks who have, more pulmonary dysfunction and lung volume impairment than you might expect. Sometimes that's because all the soft tissue doesn't really match up with what might be underneath that. Cobb angles are frequently thrown out here. I don't really make you memorize a whole lot of these other than to kind of get a general feel for the higher the angle, the more significant the pulmonary dysfunction is likely to be. And this is just one that I found. I think this is a much more up-to-date source than what's in Nagelhout, and I think a little bit more conservative. But as you get into these Cobb angles of greater than 65 degrees, and you don't have to be the one to measure and document and figure out what the Cobb angle is, but I'm just going to show you here. You take the most deformed one up top, most deformed at the bottom, draw a line sort of parallel to the base of that, and then draw a line perpendicular to those until they intersect. Yes? That's how they're figuring out the Cobb angles. So again, I'm not so focused on how do you figure out a Cobb angle, what are the places you draw the lines and all this other stuff, but that you'll hear the term Cobb angle, and that's referring to basically the severity of the lateral deformity often and a higher Cobb angle, particularly above 65%. And again, this is a little bit more recent than your text, which would indicate that these are people you need to be at least thinking about, is this someone I need to get a preoperative PFT on that might help me to determine the impact of this baseline disorder. All right. We will talk a little bit more about ankylosing spondylitis. We see a ton of these patients in the perioperative period. The vast majority of them do not have, their primary feature is not pulmonary, but we will certainly see this, and it's one of those folks that has this condition, they kind of chronically have it. What are the reasons we see these folks come to the perioperative setting? They're an orthopedic mess. They come with a variety of different orthopedic-related surgeries. A lot of them will be the folks that we present for cervical spine, lower spine surgeries, et cetera. So we will see folks with a history. It's often not the predominant condition. It is most common in white males under the age of 40. These are folks that want to be working for more in their life. So, why do they come to the operating room for procedures? Because they want to be functional again. This can become quite limiting in terms of their ability to work and be active and so forth. So that it hits young men like it does, we will see them present to the perioperative period to try to get some better functionality and walking around with less pain. But they are chronically in pain. They have stiffness. I've heard this referred to as a bamboo spine. There's a lot of issues that patients with severe ankylosing spondylitis have. And it's important to recognize, again, some of these others are big. We're mostly talking today about the pulmonary impact of ankylosing spondylitis, which can be in patients with very severe disease, very common. In that subset of patients with ankylosing spondylitis that have severe disease, they frequently have pulmonary involvement, if that makes sense. But you also need to think about this as a complex care plan that involves multiple other pieces, difficult airway being probably one of the first things you think, we finally have tubing. And then we're having trouble ventilating them in the perioperative period too. So this can be quite significant. Some of the other pulmonary, they don't just have interstitial lung disease. They're kind of like a mixed bag. They can have the intrinsic and the extrinsic components of restrictive lung disease. Overall, double whammy on total pulmonary compliance. They may also have, because they don't have enough problems, sleep apnea, incidence of spontaneous pneumothorax, etc. What's the first thing y'all think about when you have a patient who their disease condition is associated with the risk of spontaneous pneumothorax? Anybody? Same would be true for a patient with a history of blebs. Well, you'd be watching for it. We're not going to treat it unless they have it, really, but we would, because they could have a spontaneous pneumothorax that is not really something that's a major issue for them. We don't know that it's there. We would, probably get a chest x-ray on this person because we know there's an association with that, but nitrous is really the big thing. If this is someone who may be walking around with a pneumothorax, and it could be subclinical, something that's chronic, they don't know it, you would potentially want to avoid nitrous. So I just avoid nitrous in general. Again, mixed bag. You really have to assess these patients individually. What is the significance of the pulmonary and the restrictive component of their disorder? It's the gamut, from relatively mild to quite severe, etc. In a person who may have cricoarytenoid involvement, you will often do a good airway assessment. This is a person you would want to assess the quality of their vocal quality, and then again, upper airway management. We have to look at one thing. Obviously, we're going to hit that first. And don't drop the microphone when you get the airway in. Boom. All right. So that's the point at which, again, I've kind of lumped a bunch of things together. We've run through them relatively quickly. I wanted to kind of just pause there. Then we're going to kind of talk a little bit about the anesthetic management, and then we'll get into some of the other disorders that really have kind of, some very specific anesthetic implications that we'll talk a little bit more detailed about. So that's sort of the mark point there for, yes, I know I've lumped a bunch of things together, and not exactly all in just one category or the other, but we're going to just talk in general now about the anesthetic management pre, intra, et cetera, for these patients. All right. With a lot of these disorders, what are some of the presenting findings, things that we might look for we're getting a general theme here with a lot of the disorders that we've talked about, and in terms of anesthetic care plans, we're in an age where we don't get any test preoperatively unless it's indicated. There are very few things that we do routinely on all patients, but we need to know when those special circumstances exist where it's justifiable to get some of these other tests. I've mentioned that, like with scoliosis. If their Cobb angle is 90 degrees, probably a good idea to think about, has this person ever had PFTs? Do they need to be within 30 days of surgery? Not necessarily, but things that should trigger a, hey, have we ever gotten these on this person? What do they look like? Again, this is a person where, is there an indication if we don't already have additional testing and more information about this? If this person comes in and they're dyspneic, you may, and I'll mention this on a couple other slides, if this is a person who has very, very, very limited exercise tolerance, get a room air sedative and not on oxygen at rest, and then have them walk up and down the hall, catch them right after they come up walking down the hall, you can pick up some dyspnea and exertion. They may look okay sitting in the bed. We can see dyspnea in patients who are anxious, and it doesn't have to be this, but this is typically something that will stand out. This is a person who has pulmonary involvement to the point that they're walking around tachypnic. They may have dyspnea already. Whether or not we get ABGs, is this a person of evidence of walking around teetering on the edge of being hypoxemic even at baseline? That would be an indication certainly for us to get a baseline assessment of their ABGs. What is the situation here? But it's something that we need to think about. And then again, we may see evidence of pulmonary hypertension, cor pulmonale, so we'll look for some of those signs and symptoms, which we're not going to really talk largely about here. Sort of a separate issue, but look for those signs and symptoms as well. We're going to do a focused history physical. When we start to see some of these signs and symptoms in their H&P, again, they may have had prior lung function testing. They may have had prior recent ABGs. This is often a person who, has a pulmonologist at baseline. Their primary care physician or their pulmonologist is involved in their care. Not always, but if there's a pulmonologist involved in their care, very, very important. We would want these folks, if given the option, to see their pulmonologist prior to coming to the operating room to rule out any acute issues that would further put them at risk. They're going to be at risk for complications, postoperative pulmonary complications, such as need for long-term mechanical ventilation, etc., at baseline. So this is a person that we want to get their pulmonologist involved and make sure that that person doesn't have any specific recommendations or doesn't need to treat any acute issues. And again, additional preoperative testing, I'll mention a few spots here where it's something we'd go, ding, 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 nah, we don't have this, I'd really like to have it. So we'll mention a couple of those, but it's really in a case-by-case situation. Just a picture of the lung volumes, total lung capacity, normal, restrictive lung disease decreased. Tidal volume. This one at least doesn't show a huge change here. Expiratory reserve volume decreased, residual volume. Functional residual capacity normally sits here, FRC here. So we have a decreased FRC at baseline. What does that mean for us? It's less tank to fill up. So making the next jump from a person who comes to us at baseline with a decreased FRC, we have less of a reservoir to fill with oxygen. And a person who we don't want to give high doses of oxygen for a long time, it becomes a really, what's the worst of the situation for this person? But when you see decreased FRC at baseline, you think this is already a person who has a very small reservoir to fill up to begin with. Quick desaturation, absolutely true in the person who has morbid obesity. Small FRC, big person, small FRC. Again, so the major changes, this is just a different look at them from another text. I think it's helpful to kind of look at these graphically, compare those to the baseline values. If the total lung capacity is less than 40% of the predicted value, normalized for that person's age, gender, ethnic background, weight, etc., then this is a person who would be highly likely to require postoperative mechanical ventilation. What's the impact of that knowledge? What does that tell us? That should stimulate a couple of things. There's a few interventions. When we know that a person is at a significant risk of needing postoperative mechanical ventilation, Joel, you're anxious. Come on, what do you got?
We're going to talk to the patient and counsel them ahead of time.
Absolutely.
Part of the consent process.
Make sure that they're in agreement with that. They recognize that It's one of the known complications. We feel that you are at great risk of this, and are you okay with that? I mean, the decision to go forward with surgery, they need to know, we don't know that we can get you off the vent. Great. What's another implication of that?
See maybe if there's a different technique that you can use, LMA or regional or whatever.
Is there anything we can do to minimize that risk? Are we getting away with the least amount of intervention? Is this person a candidate for regional? We really can't have a good discussion about that until we get into the summer. Now, certainly when we're talking about a peripheral nerve block versus a central neuraxis block, the discussion is a little easier. That person is a candidate for a peripheral nerve block, mindful of the fact that we cannot give a lot of sedation. That's a great consideration. If we start to get into the central neuraxis blocks where we're bumping out mid-thoracic to higher thoracic levels with a spinal or an epidural, then we get into a little hairier situation because we've already had trouble with a person who's kind of teetering on the edge pulmonary-wise anyway. Great. And then, of course, the other consideration. Anybody else, can anybody at distance think of that? What else do we need to think about? Highly likely to require postoperative mechanical ventilation. This is a logistical issue. Tim said it here. You guys are probably saying it there. Don't have your speakers on. We need to make sure that we've planned for that disposition. If this person is planned to be done as an outpatient, probably not. So we need to be sure that, and sometimes it comes down to, guys, it seems a silly thing to consider, but we need to make sure that they've been cleared for. We feel this person is a huge risk. We at least want to keep them in the hospital for 24 hours. Logistically, is their family set up for that? Is that what they're expecting? And is the insurance going to pay for that? All these other things. Obviously, post-operative complications. But it's better for us to name them in front. We already know this person's at risk versus what happens these days when you have a complication that was not expected or highly likely. We don't get paid in the hospital setting. The hospitals don't get paid because that's a complication that shouldn't have happened. I think we got to be very forthright in our charting and so forth and make sure that everybody's on the same page. What is this person's post-operative course going to look like? And those are, again, that's a general guideline. It's not hard and fast. If your total lung capacity is 45%, 50% of it, you got to look at the clinical picture, these numbers, plus, again, this is somebody who we know what their total lung capacity is. And then, of course, we have to think about those patients who have, do you have right heart failure from a pulmonary condition? What are the chances of having a major cardiovascular event postoperatively? What are the implications of that? Somebody in Northern Virginia, what are the implications if we know that the risk of morbidities, particularly major cardiovascular, other morbidity is increased? They're more likely to have cardiovascular badness during the perioperative period because we know that at baseline they have core pulmonality.
You may need additional monitors, like you might want to monitor their pulmonary pressures or their cardiac output, or and be judicious about what kind of fluid you're giving them.
Absolutely. We have to be very, very, very cautious. We need to determine whether or not, at the very least, things like, folks forget this, guys, 5-lead EKG instead of a 3-lead. Any other, do we have the option of doing non-invasive or minimally invasive hemodynamic monitors to help us guide their fluid management? Maybe this is a person that we really wouldn't be quite so concerned about in terms of fluid management. This kind of ramps it up a bit. We know that they have a higher chance of behaving badly under anesthesia. So we're going to need to be looking for those things. We need to have a plan to watch for those things. Known and expected complications are much easier to deal with than, we just go into it, yeah. So we just need to think about that, and do we need to put in maybe an A-line? Maybe we want to get serial ABGs. Maybe we need additional monitors to help us with monitoring fluid status, etc. Maybe we want to have other drugs ready. Things that we think would be best suited for the patient and their particular condition. Again, we've kind of talked about this already. Low FRC at baseline, some of the implications, it affects the uptake and distribution of volatile agents. Monitor oxygen saturation during the perioperative period, that's kind of a no-brainer. ABG analysis is a case-by-case scenario. You don't necessarily have to get ABGs serially on all of these patients. Obviously, if you think you're going to need to get ABGs, it's ideal if you get a baseline pre-op. Where do they live? What is their current blood gas acid-base status, and then serial ABGs, A-lines indicated as well. I personally am in the camp of I put A-lines in advance in the pre-op holding area. You can do a nice little block. You don't have to do a bit of sedation. You don't have to sedate people to put an A-line in. Put an A-line in, pop the sucker in, have it, get your baseline, go back to the operating room, and you already have your A-line in place. That's not the routine in a lot of places, but as long as you get an ABG early on in the case, and again, you ideally want to have that arterial line in place so that you can do that. It's difficult to give you very specific. Obviously, again, I've mentioned PEEP as a great strategy for trying to minimize the amount of oxygen that you have to use on these patients. It is a little bit more of a mixed bag in terms of PEEP. Is PEEP a good idea for these patients? Would it be typically well tolerated in a patient with restrictive lung disease? We're going to talk about a number of disorders that present with a sort of restrictive pattern where PEEP is the best drug for them. That's the best thing we can do, the best intervention that we can do. I've listed here sort of as a mixed bag. Consider it. Don't rule it out. It's not necessarily something that would be contraindicated. It's not in all cases the fix-all. So I'm just putting it out there. There are many, many benefits to PEEP. It may be particularly indicated in these patients, and particularly in those folks where we're doing our best to oxygenate. We're struggling to keep them oxygenated on 30% or less of FiO2. So we need to think about that. But again, there's not a hard and fast, boom, everybody with restrictive lung disease really should have nice moderate to high levels of PEEP, etc. So I'm just kind of putting that in there as a don't rule it out. And it may be the situation where your patient simply does not tolerate that, and you can certainly act accordingly with that. But we'll talk more about PEEP and how to figure out whether it's working well for your patient, not working well. Judicious use of fluids. They already have a pulmonary badness situation, particularly those folks who have pulmonary hypertension, pulmonary congestion, other issues at baseline. So if you have a person that you add another hit to and you overhydrate them, this can be a circle the drain situation. So very cautious fluid management, particularly in patients with restrictive lung disease that is severe. Again, we've talked about a couple of situations in general. We often will avoid nitrous oxide for what reason? In addition to the patient who may have a history of spontaneous pneumothorax, we've mentioned that. We don't want to add more nitrous oxide. We'll enter that space more quickly. So that's one consideration we've already talked about. What else is a side effect of nitrous oxide that would be disadvantageous in a patient with restrictive lung disease, particularly in one that has evidence of chronic elevated PA pressures? Okay, we'll have you look that up. All right, hypercarbia is bad. All these things I've got you listed. Here's the things. I've listed them here. I didn't realize I had it on the slide. Hypercarbia, hypoxemia. There's 1,000 reasons to avoid hypoxemia, but one of the many is we don't want to elevate the pulmonary vascular resistance any more than it already is. Nitrous oxide, hypercarbia, hypoxemia, elevate PVR. They're already teetering on the edge as it is. Specific considerations for those patients that we've identified as having interstitial lung disease. We've mentioned a couple of these already. We're in a darned if you do and darned if you don't situation here in terms of pre-oxygenation. If we anticipate difficult intubation, difficult airway management, we're going to do what? Err on the side of oxygenate longer, give ourselves more time. But if we have a person that we feel like is acceptable based on their airway, based on the difficulty with which we think it will be to get the breathing tube in, we can consider somewhat abbreviated pre-oxygenation, recognizing we don't want to put them on high levels of FiO2 for an extended period of time. Once we get into we're intubated, we now have the patient who's on mechanical ventilation, we may figure out a target PaO2. What's our normal PaO2 that we go for? Usually higher than 90, right? 94, 95, that's, in that range is what we're going for in the average person. We wouldn't be happy. I'm always going for 100% if I can get it, but certainly FiO2 is not the way to go. We will definitely try to use no more than 30%, use other measures if we can to get that FiO2 down and still maintain a PaO2 in the target range we've identified. And basically, if we don't have an ABG serially being done, we're going to go by the target oxygen saturation, which may be as low as 90%. All right. We talked about the anesthetic care plan. We're going to move on a little bit to a few other, again, extrinsic diseases. These kind of go in their own category. These become sort of their own entity. Is the biggest issue for these patients necessarily that restrictive lung disease component? These are often in the flail chest, the traumatic pneumothorax, Certainly tension pneumothorax has particular interventions that we need to know about and to implement very quickly in order to save the person's life. So that's why I've kind of put these out in a different category, if you will, because when we talk about anesthetic management of the patient with a restrictive lung disease, a lot of those others that we've just talked about, you can kind of put into the big restrictive lung disease thing. These are considered basically extrinsic, chest-walled issues, et cetera, that may have a primary component of decreased compliance. Ventilating these patients may be very difficult, but clearly the reasons are very different for this subset of restrictive lung diseases than they are for the others. Have you all seen the video that was on Facebook going around recently? Most of you are probably members of the site, the CRNAs and SRNAs. There's just a little link to that. If you don't have Facebook, you may not be able to get that, but Remote Medics are the folks that put in this really, really impressive video of a flail chest that was on Facebook recently, which really kind of illustrates all of these things here that you're talking about. It's a near total flail chest, really impressive video. The paradoxical movement of the chest wall. This patient's chest wall was doing all the wrong things at all the wrong times. You're seeing this, sucking in during inhalation on the one side, the other side's like ballooning out like this massive ball, and then it's just, all this rock. This person is clearly, we're not able to ventilate this person, and it appeared to be breathing spontaneously. So there's some major intervention that needs to happen there. At any rate, clearly a very, very severely limited alveolar ventilation. If the lung volume is going into spaces it shouldn't be going into, this is, again, fairly intuitive. Clearly this is going to be someone who has arterial blood gas derangement, a very acute situation, and one for which we need to intervene. And often we're not the only ones intervening. This is often a chest trauma surgeon, etc. So we may be putting in chest tubes, a variety of other interventions. Some of the things just to think about in terms of other ways that we would get pulled into the management of a patient who has flail chest, and this is not the huge, massive, total flail chest situation, but someone who may have a smaller subset of their chest wall that is flail. Pain control is huge. Obviously, it hurts like heck to have broken ribs in multiple places. Some of the other interventions, again, that are not going to fix the issue, but will dramatically impact this patient's quality of life at that moment. And may also, as a side note, because pain is a major limitation in their chest wall excursion, they're not taking big breaths. They're breathing very shallow into Kipnik, and they may have alveolar collapse because they're just doing the my chest is killing me. We may improve ventilation because we're going to expand those lungs a little bit better when they're pain-free. So, again, we're not going to spend a lot of time on pneumothorax. I think you guys have pretty good understanding of the various types of pneumothoraces, and again, the big one being there will be some intraoperative situations, emergency situations, and patients at particular risk of that, or who have procedures that may be associated with a risk of intraoperative pneumothorax. So we need to think about tension pneumothorax as something that can happen. It's in our differential of those things that can happen in the perioperative period, and what are we going to do for that? Anybody had to do this before? Pre-hospital folks? Needle decompression. So we'll talk a little bit about that as we get further in the semester in terms of interventions, but needle decompression certainly is indicated for a patient who we believe has a tension pneumothorax. For most of the patients who have a pneumothorax, obviously we may see them come to the operating room for other procedures. Known pneumothorax, one of the biggest interventions for us is not giving these patients who already have a known pneumothorax, they come to us for some other procedure, but happen to still have their chest tube in, probably not giving nitrous oxide is a good idea. They're trying to re-expand that lung, not add more nitrous oxide into it. What are the signs and symptoms of tension pneumothorax? Classic presentation. Decreased cardiac output, hemodynamic instability. They have intrathoracic pressure that's building, it impacts their hemodynamics. You may see compression of the great vessels. This is circling the drain, not going to survive without acute intervention, is essentially the bottom line here. And again, you see sort of the same things that you might see with tamponade kind of thing, this tachycardia, you get acute hypotension, increased right heart pressures. We may see increased ventilating pressures. If we have a patient who is already on mechanical ventilation, we may see increased airway pressures. Then we've got to get into the differential diagnosis of what are all the things that can cause acute increased airway pressures, and needle decompression is certainly something to think about. Trauma patients, we certainly need to think about the idea that these patients are at risk of hemothorax. Again, we're not really going to talk a lot about that. We will mention a little bit pleural effusion. You guys will deal with a lot of patients in the thoracic surgery setting who have chronic pleural effusions. Of course, there's a lot of conditions that can cause that. Some general of these are patients who are multi-system involvement. These may be oncology patients. These may be patients who have other disorders, can be pretty sick, liver disease, etc. You can see patients who have chronic pleural effusions. And this can certainly, in and of itself, it's a space-occupying thing in the chest, and that can cause compression of the lung on that side. Obviously, big pleural effusions, bilateral big pleural effusions, would that increase your compliance or decrease your compliance? Decrease lung compliance because you've got extra stuff in the pleural space. Certainly they're at risk of infection as well. We may see patients who, we rarely are involved with the patients who come to us for placement of a thoracentesis tube. What is often the case, though, we will be involved with thoracic surgery, patients who are coming for pleurodesis. Chronic pleural effusions. Does anybody know what a pleurodesis is? Maybe you've been in a surgical ICU. Go ahead, push your button.
We did a few of them. I don't know the exact procedure, but don't they do something to the lining of the wall?
Yeah, they want to make it angry. What's happening is that pleural is pulling away and allowing that is what is typically mostly a potential space, and it just keeps allowing fluid. Maybe they have very low, systemic albumin, very poorly nourished. They may be hem-oncology patients, etc. They keep developing fluid in that space, and once it's been there, it's like those junctions that are open that let that fluid into the pleural space. They just keep forming, and they just keep getting these pleural effusions chronically. So then we'll go in and we'll drop a lung, do a one lung ventilation for a very short period of time, maybe as part of another procedure, etc. But we'll do what we call as a pleurodesis, and there are multiple strategies to do that. But what it comes down to is you're just ticking off the pleura. They'll put talc in there. They'll put an irritant, and what it wants to do is fibrose that pleura to the pleural layers together, so that there's not a space there for the fluid to develop any longer. Not a guarantee. We generally try not to talc someone more than once in a row, but you'll sometimes see them come back for that. But a major indication for thoracic surgery that you'll encounter in your travels. All right. Again, we're going to move on to a few of the acute intrinsic restrictive lung diseases. We're not going to spend a ton of time working on pulmonary edema. We will talk a lot about the one that is most specifically related and is a complication of anesthesia, because we need to know how to recognize that and what to do about that. Patients who have active acute pulmonary edema, do they come to the operating room? Not if we can help it. That's a really good reason to keep them out of the operating room. We don't really want to do that. Well, we will sometimes have our hand forced because there's something else going on. But patient that's a medical emergency. So that's kind of one of the reasons that I sort of downgrade this in terms of the overall scheme of things, is that if this is a person who their primary issue is pulmonary edema, we're probably not going to be taking them to the operating room. That's a really bad time to be doing that. They're barely able to stay alive without being in the operating room. Now, can we see patients who will develop pulmonary edema due to other conditions, not the anesthetic-specific one that we'll talk about, under anesthesia? Sure. And certainly we'd want to be able to recognize that. But ultimately, again, it's important to think about this. It's considered an intrinsic, acute, clearly intrinsic restrictive lung disease, and the primary issue may be we can't ventilate this person. We're having decreased pulmonary compliance. So we're not able to effectively ventilate and therefore oxygenate these patients, but it's often, again, something that is a secondary issue. Either we've caused it iatrogenically or etc. It's not really something that we would acutely bring a person with pulmonary edema to the operating room. There's not a procedure that we can do to help that until they get that straight with multiple medical interventions. Anybody just love the Starling's equation? This is the basic, watered down version of the Starling's equation, and certainly it's important to understand some of the components here. Kind of walking through this here, what is the net flow? We're looking at the permeability, which is this constant here. What are these values? You can see them right on here. these are essentially opposing forces. One will promote flow from the pulmonary capillary into the interstitial fluid. Some of these forces promote flow from the interstitial fluid back into the pulmonary capillary. It's important to know which way that particular parameter, what sort of flow does it promote, flow into the capillary or flow out of the capillary. But it's also important to know at the end of the day, this issue here. At baseline, healthy folks will have relatively small, but the net flow is going to be where? From the capillary into the interstitial fluid space, and where does that go? Into the lymphatics. All right, again, opposing forces. So again, it's important to keep that in mind. You guys, I think, are somewhat familiar with this in terms of if we increase the hydrostatic pressure in the capillary, which way does that flow go? Into the capillary or out of the capillary? That promotes flow out of the capillary. So based on looking at this equation, if we increase the pulmonary capillary hydrostatic pressure, what's going to happen? Fluid gets pushed out. Of all of the factors that will promote pulmonary edema that we're going to talk about, that's really the most common one, is increased hydrostatic pressure in the capillary. So that's the most common one, and we'll talk about some of the disorders associated with that. Certainly, increased permeability is an issue as well. Those are kind of the two biggest and most important factors that promote pulmonary edema. But kind of just walking through this, put this equation on a piece of paper, kind of walk through it, make sure you know what promotes flow out of the capillary into the interstitium, essentially into the lungs. One of the major causes of pulmonary edema, of course, is those patients who have what happens in cardiogenic pulmonary edema. The heart can't move the blood out through the left ventricle. So the next structures that appear in the circulation after the lungs is the left heart. This is the left atrium, what valve? Mitral valve, into the left ventricle, out to the systemic circulation. If there's some backup in that system, increased left ventricular end-diastolic pressure because someone has heart failure, they can't push that blood. If it can't get out the left ventricle, where's it going to go? Back into the pulmonary capillaries. So cardiogenic pulmonary edema, the primary issue here is the heart can't pump well. The heart's the problem. Defining feature of this and what causes them to have pulmonary edema is that they have increased pulmonary capillary hydrostatic pressure in the pulmonary capillary bed. That's going to promote flow of that fluid. It's got to go somewhere, so it's going to go out into the lung and the interstitium. We're generally talking about situations where the heart is so poor at pumping blood that you have pulmonary capillary pressure greater than 25 millimeters of mercury. Again, this is a left heart issue. It's a cardiogenic pulmonary edema. It's caused by the heart. That's the issue. So what do we do to fix this? Fix the heart. You got to promote forward flow through the heart. So the major issue is backflow. Get the flow going forward. Get it out to the periphery. You guys are well familiar with all the things that will do this. Some of the conditions most commonly associated specific cardiac pathophysiology. We're going to talk a lot about mitral valve disorders. Again, left atrium, left ventricle, the valve between those two things. If you have a mitral valve dysfunction, things are going to backflow often into the pulmonary circulation. Again, more generically, anything that causes an increased left ventricular end-diastolic pressure, volume, that's going to end up backflowing into the lungs. These are things you're quite familiar with. Again, increases pulmonary capillary pressure until the rate of fluid exudation exceeds the lymphatic range. Again, we're talking about someone where promoting outward flow, how much is going to cause them to have pulmonary edema? Well, the lymphatics can only absorb so much. When we exceed that, it's got to go somewhere beyond that, right? The lymphatics just like a govern. It's going to govern the amount. The lymphatics can only do what the lymphatics can do. They don't have this massive capacity to suck up more flow acutely, so that's going to go out into the alveolus. And clearly, then we have a situation where we're going to have trouble. What are we going to have? Collapse of the alveoli. There's not supposed to be fluid in the alveoli. There's not supposed to be this fluid in the lungs in general, so we're going to have decreased lung compliance as a result. Patients who are awake and so forth, they have rapid shallow breathing. They may overbreathe the vent. So we may have a person who's not fully paralyzed under anesthesia. We may see that. That's probably not the first thing we're going to notice. What's more likely that we'll notice? We may see frothy sputum. We may see hypoxemia. or rule out, what's our differential diagnosis, but obviously we're looking for things like change in breath sounds, change in ventilating pressures, decreased pulmonary compliance. It's a restrictive lung disorder fundamentally. And of course the body can just go, what the heck's going on? So sympathetic nervous system stimulation. In terms of the anesthetic management in a patient who develops cardiogenic pulmonary edema in the perioperative period, obviously, again, fix the heart. What's going on here? The heart was pumping fine before. Did we just overload its capacity? Or is this someone who has an acute issue? What's probably one of the things that we would most likely see someone develop cardiogenic pulmonary edema in the perioperative period? What's the most common cause of acute regional wall motion abnormalities in poor EF? Ischemia, significant ischemia. So, that person who they present with this, we've got to be thinking about, is this a person who has a history of ischemia? I mean, that's going to be a common reason for this. Certainly we can just overcome their heart's capacity. We push them to the limits of what their heart can do. But if we have a patient who develops ischemia, this is something we need to be thinking about. PEEP works well in these situations. Again, you can just think of it as that pressure kind of pulling back pressure. PEEP helps expand those collapsed lung units. It also helps with oxygenation just in terms of stenting some of those open. Pharmacological therapies, this is very specific to the person's cardiac condition and their hemodynamics at that moment. We are highly likely to require additional hemodynamic monitoring to try to help us figure out what's going on here. That's not the focus of our discussion. And then, of course, very, very cautious management of their fluid status. All right, non-cardiogenic pulmonary edema, and I've added this here. If you had a set of slides that didn't have this designation on here, this really falls under Nagelhout. Makes this quite clear. And the primary issue here is permeability, but you do have elevated pulmonary capillary hydrostatic pressure in non-cardiogenic pulmonary edema. So that's kind of a mixed bag. You had to pick one that was a bigger issue than the other. It's associated with both of these things. Permeability is probably the bigger issue, but you do see increased hydrostatic pressure in patients who have non-cardiogenic pulmonary edema. A lot of the situation, though, again, becomes sort of a mixed bag. You got, flash pulmonary edema from some of these situations. That becomes a big issue. The one I want to talk a little bit more about is negative pressure pulmonary edema. Why do we talk about this? When do we see negative pressure pulmonary edema in the perioperative period? We pray and pray and pray and pray. We pray we don't see laryngospasm, and then after an obstruction, upper airway obstruction in someone we've just extubated, if we have a significant laryngospasm, we pray and pray and pray. Okay, this person please not have negative pressure pulmonary edema. But this is a known complication. It's something that happens. It can happen after post-extubation laryngospasm or partial obstruction. So that's why I'll tell the students that I'm working with, I want pristine airway post-extubation. Not a time to be looking away, flitting around, charting, walking away from a person. Now, it can take very, very, very little obstruction, not even a complete obstruction, to cause a negative pressure pulmonary edema. So post-extubation, not necessarily the person who laryngospasms always, just, what about a person who acutely loses an airway just because they obstruct because they're sleepy? What's the causative factor of negative pressure pulmonary edema? I'm trying to suck in air against a closed airway. In the case of laryngospasm, that's a closed glottis, but you can see this after a partial or complete obstruction that is non-spastic or reflex arc mediated in general. So think about this as something that can happen. That's why we probably see more of this than just those subset of patients who have post-extubation laryngospasm, and you're not out of the woods if you get to the PACU and you don't see evidence of this. What would be the primary presenting symptom? Obviously in a person, it is really important. Here's something to remember, guys. Because we will not always see the evidence of post-extubation or negative pressure pulmonary edema after a partial or complete obstruction, if we know that we had one of those situations and we saw the person rocking, please tell your PACU nurses. There's sort of this like shame and blame game that, I don't want to admit it. I escaped disaster, so I don't want to tell anybody about it. That's natural. That's just a human tendency, folks. But it's really important for our PACU nurses to know that the person had any significant degree. If we recognize this as a laryngospasm or as a obstruction, they need to know about that because this may not manifest immediately. This is not necessarily a circle the drain in 2 seconds kind of situation. We can have pulmonary edema where they're able to handle it initially because they're nice and awake, we've been stimulating them, and they're able to compensate. but they're going to poop out a little bit in the PACU. The presenting symptom that we will often see from this, again, rapid shallow breathing. How does that become difficult to notice? They just woke up. They're just waking up. Lots of people breathe shallow after they emerge from anesthesia. Maybe they're in pain. Maybe they have other issues. So rapid shallow breathing, hypoxemia. Unexplained hypoxemia in the PACU would be a really big one as well. This is a person who we just can't keep their sats up. They've required oxygen longer than we think they should have, etc. Predisposing factors, a lot of this you will see kind of lines up with a person. Obviously, people are already kind of sick at baseline. They already have other risk factors for pulmonary edema in general, in terms of their permeability, in terms of their left heart function, etc. This creates a big increase in, this is you suck in abruptly and you kind of suck fluid. So if you already had decreased permeability, or increased permeability, I should say, and then you suck in, you're going to promote additional hits in your cell membranes there. So you're going to have doubly increased permeability. So if you're already at risk for permeability situations, already sick, already have elevated left heart pressure, so you have multiple factors that would promote pulmonary edema, you're kind of teetering on the edge of promoting fluid out of the capillary space already, you're going to be more at risk for this. And the other situation is sort of counterintuitive, but if you think about someone who's very young and muscular, males tend to have more chest wall mass. Why do they develop negative pressure pulmonary edema after laryngospasm more readily than women? More negative inspiratory force and negative inspiratory pressure generates. So you're usually a bigger sucking force. So it's more likely they're going to suck that fluid in. Again, can be up to several hours later. If we have a significant, a really big laryngospasm, or someone who has any trouble at all post partial obstruction, etc., one of the implications here is we're going to watch them for a little bit longer, because it does not necessarily manifest right away. It can be hours later. So we will often keep them in the hospital and or in a unit. If they develop any degree of pulmonary edema, do we automatically re-intubate them? Not necessarily. And that's one of the big things. Again, some other things to look at. Chest x-ray is going to be really helpful in this situation. It does show up just like pulmonary edema always does on chest x-ray. I want you to think about this order of the game here. It is not necessarily the case. Obviously, if we know that they had a big issue, they had a really bad obstruction, we required neuromuscular blockers again, we re-intubate them. We're not going to necessarily extubate them immediately. If they're already intubated, obviously, even in that situation, we want to try to get away with as little as we can. Oxygen, CPAP, and or PEEP, if they're mechanically ventilated, is really helpful. But a non-intubated patient, think about it in that progression, they're still a candidate for BiPAP. So oxygen therapy, if they're still dropping their sats, positive pressure of some sort, doesn't necessarily mean you automatically intubate the person, but positive pressure is known to help. BiPAP, CPAP, we can keep them breathing spontaneously. That's often indicated, because these are often patients who we thought we'd extubate. And if we had to re-intubate them, a relatively young, healthy person, because of a severe spasm, and we've re-intubated them, what's going to be the case? They're not going to tolerate controlled mechanical ventilation very well. They're probably awake and alert and that sort of stuff. So we, again, the decision is a case-by-case situation, but if you think of that progression, oxygen, positive pressure, CPAP, BiPAP, if we can get away with that, and then to the more aggressive forms of positive pressure ventilation, if they're on a mode where we can use PEEP, PEEP is indicated, and then, of course, in a really bad pulmonary edema situation where they're having severe issues with oxygenation, we may go ahead and have to put them on a vent, on controlled mechanical or assisted ventilation. Fluid management is, of course, a big factor. Didn't start as a cardiac or other issue, but we need to really watch promoting more fluid flow into the space. All right, so non-cardiogenic permeability issues, some of the ones we'll talk about here. Here's the bottom line. You guys are familiar with patients here with pneumonia, with ARDS. You've maybe even dealt with some patients with trolley. I'm going to really focus in on the anesthesia-specific one, and that's because there's an increased risk of aspiration in the perioperative period in anesthetized patients. So what is the sequela? What are the sequelae of that? And management of aspiration pneumonitis. That's really going to be the focus here. Again, you can see various syndromes. Of course, in our situation, this is a person who has chemical pneumonitis. This is someone who gets low pH, high volumes of gastric fluid into their lungs. There is this immediate badness. We have put a corrosive material into the lungs, and there are sequelae associated with that. It is definitely associated with lower pH. Cut point often, they identify in the literature less than 2.5-ish. And again, when we start to get up to higher volumes is key. Pneumonitis from perioperative aspiration, often called Mendelssohn syndrome. That's just a classic thing to know. Mendelssohn syndrome. Pneumonitis associated with a perioperative aspiration. Again, what happens to the lungs? They start to go, what in the heck? And they get this sort of bronchospastic reaction. So we will see that happen in the acute. Some of the patients who are at particular risk for aspiration during the perioperative period, you'll notice these are folks, so if two patients have aspiration of the same volume and same pH, would a person who is obese be more at risk for the aspiration pneumonitis than the other? No, these are risk factors for aspiration to begin with. So what are the patients who are at risk for aspiration? Those are listed. Again, if they have a big belly, ascites, more back pressure on the esophagus, more likely the esophageal sphincter will be incompetent. Obesity, patients with diabetes have gastroparesis problems, so there's more likely to be more volume sitting in their stomach. Obviously, patients with neurological deficits, etc. So I think a lot of these are somewhat intuitive. Hiatal hernia, obviously there's stuff up under the diaphragm. Inadequate anesthesia. So we have a person who is not necessarily asleep, not necessarily awake. What goes on in that situation? All of their airway reflexes, think of all of those. How many starting your airway reflexes, your esophageal sphincter tone, etc. It's all wonky. So things are just not protected. You want to have them totally awake or totally asleep. Not a situation to be sort of in that in-between. If they're in between, what do you want? Still have an endotracheal tube in place. Cuffed endotracheal tube, which is not 100% guaranteed that they're not going to aspirate or get gastric contents in their lungs, but we want them totally awake so they can protect themselves, or totally asleep. And until they're totally awake, we want to protect their airway with a cuffed endotracheal tube if we can. When do we come through lighter planes, going to induction, and coming out of them with emergence? So those are the two greatest frequency time periods. You'll see various sources that will tell you induction's more risky than emergence. Emergence is more risky than induction. I'm not going to split hairs over that. Induction and emergence are the highest risk periods for aspiration. What happens, again, there's this staged out process. The book has a really nice description of this, so we're not going to go into a great deal of that. Again, you just have to remember, the big thing here is to remember there are multiple phases of this. The initial phase, it doesn't matter how quick you try to get that crap out of their lungs. It's on contact. So if anything has gotten in their lungs, this is a person who is at risk for aspiration pneumonitis, a chemical pneumonitis. It causes this profound reaction just by the fact that that liquid and stuff has touched their lung tissue. It's not supposed to be there. You guys have aspirated before, right? We're going to get something down the wrong tube. It doesn't matter how quickly you try to get that out. I mean, you forcefully cough, and it's like you just feel badness for a little bit. And most of us, of course, with very minor aspirations, do quite well. Again, here one of the primary features is hypoxemia, unexplained hypoxemia. You may have an aspiration that's significant and you didn't notice it. So it's important to remember that. Patients, especially if you have a patient who had small bowel obstruction, had a lot of stuff sitting in their NG tube, etc., you may have an amount of fluid that has been aspirated. We never see it. You can suck out their endotracheal tube and you never see that there was anything down in their lungs. You didn't see it with emergence. You didn't see it with induction, but they could certainly have some aspiration going on. It's more rare, and especially more rare that they would present with really fulminant signs of aspiration pneumonitis. But it is possible that a person had zero evidence of a significant aspiration and still have aspiration pneumonitis post-anesthesia. So there's always that upside. Again, so now we put a couple of things in our post-operative unexplained hypoxemia. What are the other things that I talked about? Unexplained hypoxemia in the post-operative period. Maybe we didn't notice that something happened, a partial obstruction, so we may have negative pressure pulmonary edema could be an issue here, and now we've got this nice, fun aspiration pneumonitis going on. Again, some of the secondary injuries may not occur until much later. Maybe the initial reaction not so bad, but then we get this flooding, the inflammatory response. Another situation where a person really needs to be watched for an extended period of time. The known aspiration, we really want to watch. The good news about this one is they will typically manifest their badness within a couple hours. So if you have someone who you know had a pretty minor aspiration, you may extend the period of time from 45 minutes to 2 hours, maybe 3 hours. If they have significant hypoxemia in that time, they need to stay. But if they haven't, this is an outpatient, you think they might have had a little bit of an aspiration, you see no evidence of badness, and you've watched them for double the usual time, they're probably fine to go home. Again, some of the risk factors, which we've kind of talked about here. Anesthetic considerations, what do we do for this? There are a variety of pharmacological interventions. Many of them are aimed at addressing the two correlates that I've mentioned. Very, very low pH is associated with a higher degree of, aspiration pneumonitis, more likely to get that, and high gastric volumes. So we may give gastrokinetic agents like Reglan to try to promote forward flow through the stomach. We may give particulating acids. We may give, is it useful to give an H2 blocker 10 minutes before we go back to the operating room? Not going to do anything for you. It might help them with postoperative nausea and vomiting, because very acidic gastric contents may be associated with that. But as far as the risk of aspiration, if you haven't given it well in advance, not really going to be helpful for minimizing the risk of aspiration pneumonitis, but certainly something that we will see given. What other measures might we take to minimize the risk of aspiration? Again, we're talking about measures to minimize aspiration, not necessarily measures once you've aspirated to do. We'll talk about that in a second, but gravity helps. Head a bed up in a patient who has a high risk of aspiration. If you can't intubate that way, you may just keep them up till right before. I'm of the mindset, because I've had get my feet wet aspiration in the past. Anybody, let's be mindful of this, guys. Anybody who's been in the hospital for a period of time, particularly if they've had a prior surgery, please be sure you listen to their bowel sounds. Get my feet wet aspiration from a person who had an ileus, no NG tube in place, small bowel obstruction, those sort of situations. I'm of the mindset these days, in our practice in my institution, has been put an NG tube down, take it out, because we don't want to wick and give a path. You put an NG tube and get an open sphincter, because that NG tube is compromising that sphincter. So we'll put an NG tube down if they don't already have one, and then take it out prior to induction, induce. It decreases your ability to ventilate. That is not practiced in every institution. Many institutions will have, what you do need though, 2 suctions. Don't count on the NG tube being connected to suction the entire time if you only have one. You're going to need that in a pinch. So always, if patients at risk for aspiration, why would you not have your suction Yankar right there ready to go? If they need an NG tube to suction during induction, put it to suction with somebody else's suction. Bring in a portable suction if you have to. Head a bed up. What about cricoid pressure? I don't know if it helps. The literature is equivocal on this. It is culture. We do this. I do it. I ask for it. If they're going to do it for you, you want to make sure they maintain it until after you've put the endotracheal tube cup up. Lots of us do this. Whether or not it really does help in terms of preventing aspiration, that's debatable. Okay. Inducing my patient, maybe I did or didn't know that they had a risk of aspiration. Maybe I was kind of alert to this, and all of a sudden I see, this in my situation it happened. We pushed propofol, didn't see anything. We were doing a rapid sequence intubation. Unfortunately, for this patient, we were on a urology bed. This was a person who was acutely obstructed. It was the middle of the night, 3 o'clock in the morning. This person came, just had a big, 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 huge belly. We could not, those beds do not reverse Trendelenburg. You can't get to the person, which means I had enough fluid to flow over 3 or 4 inches of space and still get my feet. And when did it happen? Probably about the first molecule of succinylcholine that hit that person's vein. I mean, just everywhere. Your first intuition in this case, folks, is what? Well, you get Tourette's. You get Tourette's and you pee your pants. But after you finish with the cussing and swearing, then you will, it's not intuitive, I can tell you, to put the head of the bed down. Let's get more of that going. Let's promote, but that's the first thing to do, or turn, in my case, we had to turn the person to the side. You got to get it out. It's coming. You got to get it out. So get it out. It is effective to suction the mouth and clear the oropharynx, because what's going to happen is a bad aspiration. I'm going to want to intubate this person, and I've just given them succinylcholine. colon, I got to get all that stuff out of the way. So we'll go ahead and clear out the mouth as best we can with whatever you can. Certainly apply oxygen if we can. We're going to take the face mask off if we have to get the stuff out. And then once we intubate that person, one of the things that's definitely not a good idea is to plan to do aggressive and deep bronchial suctioning. It's there. Again, it starts to cause badness on contact. So this is stuff that's out there. I don't really love if I've got a slug of gastric contents in the endotracheal tube. Ideally, the cuff is up now, so I'm not going to be putting more in there. I don't love the idea of then hooking them up to a ventilator and blowing it out into the periphery of the lungs. So the confusion becomes, do you suck them out and get that stuff out of there, or do you just put them on the vent? In that situation, if you're sucking through the endotracheal tube, you're not going out into the deep periphery of the lungs. You don't want to push that stuff out, further out. You can suck to the tip of the endotracheal tube with a regular soft tip suction, or you can put it down through the endotracheal tube, but don't keep going out. These lungs have just gotten ripped up by acid. You really don't want to be bronchial suctioning and deep suctioning. You don't want to be putting saline and washing it out in there. Bronchoscopy, not typically helpful. Again, the initial damage is done. We're already causing this sequela that's going on. So that becomes a controversial issue. Do you bronchial suction or no? No. Can you suck out through the endotracheal tube, though? Just the tip of it, what you can see, sure. And then once we put them on the vent, PEEP is advantageous. Antibiotics, not necessarily helpful. This is not a infectious situation. They may have inflammatory processes going on. They may look a lot like an infected person. They are certainly at risk now for a big aspiration, at risk for ARDS, acute lung injury, and so forth. The discharge is related to, you're not going to discharge my guy who had the massive aspiration in the middle of the night. He was already an inpatient anyway, but discharge is, how long do we keep them? If they had, again, what we see is a little bit of an aspiration, do we need to keep them for longer? Yes, at least a few hours, and then after that, if they have no evidence, you're good. I'll stress again here, we're not really going to talk a lot about ARDS. One of the big things that comes up is whether or not we can mimic that person's settings. You guys deal with patients with ARDS a lot. You're quite familiar with the lung protective strategies, some of the very aggressive mechanical ventilation strategies. That's one of the mainstays of care for a patient with ARDS. We need to be able to mimic those things as best we can if we're lucky, because we're going to put them under anesthesia. So we're going to paralyze, lower their metabolic rate. Their oxygen needs are going to be less. We tend to have less issues with these folks. The modern ICU, the modern anesthesia ventilators can do much of what we would do. We'll look at the maximum settings in terms of high PEEP, etc. We cannot do oscillation ventilation. We cannot do any sort of these, there's adjustable pressure. What am I thinking of? We don't have it in the operating room, so I haven't used it. Adjustable pressure, like high frequency ventilation, that's circulating. They do that in some ICUs. What did you call it? Bi-level. We don't have the ability to do all those things. We just basically have controlled mechanical ventilation, and we can do certainly inverse ratios if they need that, very, very high levels of PEEP, etc. At one time, we had to worry about the ventilator that we had in the operating room not being able to do those things. Most modern anesthesia machines can, but we need to assess that situation if we have a person. Again, are these patients coming down for procedures in the operating room to a large extent when they're in the acute phase of ARDS? Not so much. So we're really going to downgrade this to a large extent, not because it's not important, it's just that we've dealt with it a lot and we don't see a lot of these patients in the perioperative period. You're quite familiar with the care and management of these patients and what that is. In terms of anesthetic implications, again, sometimes we have to rethink. For those of us who are not dealing with ARDS patients, often we have to think about things like permissive hypercapnia. The bottom line there is they've got a pulmonologist. They're being seen by a pulmonologist upstairs. What are our goals and endpoints upstairs? Again, we often have an easier time achieving those things in the perioperative period than they do upstairs, or downstairs, wherever it might be. And certainly, if we have to put a person, there's often, this person is very unstable, they're hemodynamically, they've still got some ARDS going on. Well, maybe if we go to prone positioning would help them. Maybe just a mention there that prone positioning may actually be good. It's difficult to do in the ICU. We do a lot of prone positioning in the perioperative period, so not necessarily a horrible thing. All right. Acute lung injury associated with transfusion. I believe most of you are familiar with this as well. A couple of big points. Platelet transfusion, more highly associated with trolley than some of the other products. Certainly surgery, the acute stress associated, the response, immune response and other to surgical conditions may put this person at risk for a trolley that was not previously. Again, not something that we really see a lot. And then in terms of the pathophysiology, I think you guys are quite familiar with that. In terms of the management of these patients, again, they can present as the patient who needs protective lung ventilation. What are the components of lung protective ventilation? You guys know that part? Relatively low tidal volumes. There's several components. Relatively low tidal volumes, lung protection, ventilation. I see mouths going here, but not saying. PEEP, judicious use of PEEP, particularly higher than the levels that we might use with other situations. Permissive hypercapnia may often be considered kind of part of that lung protective. We're going to deal with a little bit of permissive hypercapnia. Those are the major components. Alveolar recruitment maneuvers, often part of an open lung strategy, especially in conjunction with PEEP. We'll talk about that more next week. Again, some of the other things to think about in terms of if this were to be something that we developed in a perioperative period situation, obviously one of the fixes is stop the transfusion. But again, those are not patients that typically come down. They have active acute lung injury and issues going on there. That's not the person that's going to be a good candidate. We don't have a choice sometimes. I don't mean to imply that we would never do surgery on that person, but these are patients who are in ASA what? Acute lung injury, serious ARDS, serious trolley, where that's sort of the major component going on. Take your pick. I mean, that's a really high. So I want to talk about a couple of things here because we have about 10 to 12 minutes. I will not go over, but I want to mention a couple of things. We're going to get to ventilatory strategies next week. I want to give you a little primer. The first thing I want to note is that I put up a little, for those who are not intimately familiar and loving on mechanical ventilation as of right this minute. My slides are not there. I've got a couple I'm going to show you here. There's a required reading article that largely talks about some of the components of an open lung strategy, if you will, that we can do in the perioperative period and why those are so important. The reason, we ablate the sigh, and patients are extremely high risk for atelectasis, which we've already mentioned. So we're going to talk about strategies to overcome those things. I've also put this supplementary handout in there. It will talk about the capacity, what things our anesthesia ventilators can do, some very basic things. We're going to get into, I really want you in this lecture hour next week to explain the basic characteristics of volume control and pressure control ventilation. We really, in some years, as we do this discussion, cannot get much farther than that. So I want to try to tee us up for getting to the other objectives other than just to what is the difference between volume control and pressure control, like to the discussion of why would we choose one over the other, not just how do they work, but how do we set that up if that's our mode, but why would we choose that? Some of the strategies for obstructive and restrictive disease. Again, constructed basic plan for mechanical ventilation of the adult patient, healthy and then with specific conditions, so we'll try to get to that. Again, if we can get to it, we'll look a little bit about the airway pressure and flow waveforms. It's really important that you can look at those waveforms, the pressure time and the flow time waveforms, and understand what information is shown there and what can you get from that really quickly. There's an additional sort of parameters of assessment that you can utilize because you have those waveforms available to you. So I want you to kind of get used to looking at those and used to figuring out what that information is. What is that telling me about my person and how am I doing well with my ventilatory strategies? And then again, what are some of the appropriate goals? That we kind of already get. So that's the handout that I put together. We've talked about a couple of things already, and because we have a couple minutes, I'm going to talk about these right now. The first one is we've talked a little bit about IE ratio. So if you haven't really looked at this, again, the primary modes that we utilize for our patients. Let's start with this. We mentioned this a little bit earlier, and I'm going to give you guys a copy of this. Here's the primary modes that we have here. We can do spontaneous or manual ventilation with zero assistance whatsoever. We do a whole lot of that, yes, in the awake patient, and sometimes patients with LMAs, sometimes patients emerging with an endotracheal tube replaced. We give them zero assistance whatsoever. Toggle the switch from ventilator to manual, open your APL valve. Totally unassisted ventilation. We have monitors to tell us when they're not breathing for a long period of time. We can do CPAP by dialing up the APL valve to a higher level of continuous positive airway pressure. So we kind of have those modes, but don't go looking on your vent for a button that says CPAP. You're on manual ventilation. If you flip it to vent, no CPAP. You're on a mode, one of these other ones. All of the anesthesia ventilators have volume control. In this day and age, most of them have pressure control. Smaller subset of them have the patient-triggered mechanical ventilation modes. So you'll spend a whole lot of your time, with good reason, because we anesthetize paralyzed patients, we'll spend a whole lot of time in the fully controlled mechanical ventilation modes. If this isn't already intuitive to you, this is not necessarily what you've been using in the ICUs. What do we use in patients who are not fully paralyzed and sedated? We use assisted modes, assist control. They may look a lot like these other two modes, but these are not time-triggered, time-cycled modes. There is some patient trigger component along with that. So, we have to fundamentally think about that. And again, it's important for us to, this is a really important part of your care plan. When you walk in the room in a day, what vent do I have? You would think that would be pretty standard. It is not. You can always do these. You can always do volume control. Anything beyond that, I'm having a happy day if I have pressure control, especially if I have a hybrid mode. Newer vents have a pressure control with a volume guarantee, some nice best of this and the best of that. We'll talk about why that would be important, but you just don't know what you have, and you need to know what you have because it will be a major part of your anesthetic care plan for that person. So we're going to dive in first to those controlled mechanical ventilation modes. And again, they're time-cycled, time-triggered. Time-triggered, time-cycled, I suppose is the best way to put that. That's where we're going to spend a lot of our time. These other parameters are non-mode specific. Regardless of the mode that we might be using, we have to set these other things, and we've kind of started to talk about some of these things. Whether or not we're going to use PEEP, what respiratory rate we might use. We're lucky we have end-tidal CO2, so we can make changes in minute ventilation. One of the primary determinants of minute ventilation is your respiratory rate. So we can make adjustments in minute ventilation because we have end-tidal CO2 to help us guide that change. IE ratio. We've talked a little bit about why that's how we talk about this and manipulate variables in the perioperative period, because we have. But you need to know what that is and understand why you would make a particular change or not. We have to set the pressure limit or the pressure max. This is a intervention. I will not allow, this is the pop-off on your vent. I will not allow under any circumstances, no matter what happens with this person, they sit on their belly, they do other things, I will not allow it. This is kind of like my APL valve setting for the ventilator. Irrespective of what anything happens, it will not deliver more than this maximum pressure. So you have to set that in the background. Whatever mode you're on, you have to set that P limit or the P max. It'd be nice if the ventilator companies would all name it the same thing. They don't. They can't possibly make it that easy for us. So they don't call it the same thing. And you need to understand what I'm talking about here versus some of the other things, other pressure parameters that are not necessarily an intervention, but a monitoring mode. So we can set a monitor and an alarm, or we can even set a setting in pressure control ventilation. We can control that within the mode, but this is outside of the mode. Anesthesia ventilators allow us to set basically an APL valve for the ventilator. So that is key. And then, of course, the FiO2. We're going to pick off one or two of these little things, and then we'll end on that. Again, goals, those are pretty intuitive. Let's get into first. We'll talk about PEEP next week. How much PEEP, how do you set it, all that other stuff. I want to talk very quickly about FiO2. Obviously, we've talked at length about pre-oxygenating patients with high FiO2. That's not ideal, but we do it because the risk-benefit ratio is better when we do it than when we don't. We have to fill the tank because we're about to make them apneic. We try to reduce the inspiratory oxygen levels as soon as we possibly can. And again, adjust the FiO2 as indicated. Thinking ahead is if we're about to turn our patient prone, let's say we induce them, we have them on the bed, we're all settled, we're good, we put them down to 30% FiO2, great. But then we're about to turn the patient prone. Hello, they could go apneic. We have patients who get extubated in the prone position or during the turn, and you better have had them on 100% for a few minutes before that. So anticipate those things. It's okay to turn them up to 100% FiO2 for anticipated issues like that, or turn off oxygen in a fire risk situation in a patient who's not in a tracheal tube in place, or et cetera. So there's situations where we'd adjust because we know what's coming, and anticipation is huge. And then, of course, recruitment maneuvers, open lung strategies will help us to minimize the FiO2. How do we adjust the FiO2 on this machine? I want 50-50. So I want 0.5 FiO2 on a nitrous oxide and oxygen mixture. What do I dial on this? We're in the maintenance part of the case, so I don't need high flows. Why would we do high flows at the beginning? Give me an inhalation agent, so I want to get that on board. So I'm in a maintenance phase of the case. I want 50% FiO2 with a mix of nitrous oxide and oxygen. I will dial this little 1 liter, 1 liter. We keep our inhale flows with sevoflurane. We keep them around 2 liters-ish. If I'm doing isoflurane, I can go low. How low? Can I go down to 0.25 total flows? Total? Probably not. Usually around half a liter per minute. So 0.25 of those two. So that's a 50-50 mix. Now, if I want to get 50% FiO2 or 0.5 FiO2, and I'm using yellow gas and oxygen. Hold that thought. If I have 1 liter O2 and 1 liter air, what's the FiO2? Is it 50? Is it 0.5? Does everybody understand how you calculate that? Percent of, what percent of my total flow? So we know the denominator here. What's the denominator? 2 liters total flow. How much of that 2 liters is oxygen? What fraction of the inspired gas is oxygen? We have 1 liter of oxygen, so that's 1. How much of the air is oxygen? Thank you. 0.21. So 1.21 out of 2. So we adjust FiO2 on these vents with the manual flow meters by adjusting the fresh gas flow. What if I'm running desflurane at 7%? Does that impact the FiO2? We don't worry so much about that. It's mostly, this is the carrier gases versus the stuff I'm putting into the carrier gases, distributing amongst that. So I mostly worry if in terms of FiO2, I'm worried about these guys. I don't add in, I don't take 100% minus 7% desflurane and then figure out the FiO2 of the remaining. It's the FiO2 of these carrier gases. So that's FiO2. What about this guy? How do I adjust FiO2 on this one? You cheater. You take this guy, you tell it what air, these machines, you tell it what 2 gases you want to mix, and then you tell it the FiO2 that you want, and look, lo and behold, it will automatically, and it gives us these little fake flow meters. That seems so silly to you guys right now, doesn't it? I need a picture of a fake flow meter. We just need that. We just do. We need it. You dial in 50%. You hit the hard button, turn the knob, adjust it up or down, hit the hard button again, and you get the FiO2, ta-da, at that magical flow rate, and it figures it all out. Cheater. Cheater, pumpkin eater. All right, so then I'm going to just go on to, I want to look at IE ratio. I want to give you a heads up on some stuff that you need to be able to figure out. Where's my IE ratio? And I will make all these slides available to you. I just want to review those. PEEP. We'll talk about PEEP, initial vent settings. We'll talk about the pressure limit, the pressure max. So we're going to talk about IE ratio in here somewhere. Come on, IE ratio. All right, let's say we have a person who's on mechanical ventilation. Their total breath rate is 10 breaths per minute. I have an IE ratio of 1 to what? What's a good initial setting for IE ratio? 1 to 2. What's their I time? I time. That means honey badger. Don't care. The time. I get a breath every 6 seconds. 1 to 2 means if I take that 6 seconds and I separate it into 3 parts, 1 part is inspiration, 2 parts are exhalation. 6 seconds into 3 parts, 2 seconds for inhalation, 4 seconds for exhalation. So you can figure out your I time. So kind of play around it in this next few days with IE ratios, and if you make adjustments, what does that do to your I time? Exhalation time, what does that do to your IE ratio? We need to figure that out and figure out why you make various changes. It's helpful to start paying attention to the inspiratory times. because I want you to soon get to the point where you can manage patients who need spontaneous or assisted modes of ventilation, patient-triggered modes. And in those cases, you're going to dial in inspiratory time. It's helpful to know what that is typically for your patients. All right, enough for one day. Thank you. I'll see you guys next Monday.
Did you say low peak? I was confused about that. To like protect the lung.
Generally, in my experience, I've had to use higher peak.
Higher peak.
Yeah.
Okay. Okay, thank you.
Higher, more likely. It's good. So acute lung injury.
We don't see a ton of it in the cardiac patient, but my experience has been higher.
Okay.
About that liters per minute thing. So you said 1 liter of oxygen and 1 liter of air. So it's 1.21 over 2 liters. If it was 2 liters of oxygen and 1 liter of air, would it be 2.21 or would it be 2.3.21?
2 liters of oxygen.
And
Sorry,
2.21.
2.21.
Okay.
Because you have 1 liter of air,
Right.
so that's 0.21.
So it'd be 2.21 over total 3 liters. That would be your percentage. So you just added 0.21 to the oxygen.
Correct.
Okay.
Let's say you had 2 liters of oxygen and 2 liters of air. So that'd be 2.21 over 4. 2 times 0.21 because each liter of air has 0.21%. So 0.42.
Oh, okay. I see what you're saying. Okay, so multiply how many liters of air times 0.21 and then add that to your total liters of oxygen. Okay, that makes sense.
Is this it? Yes. Is that it? Yes, it is. Thank you. It's in the back. Thank you. I got mostly out of the door. Yes.
Like
My
here,
new
where
thing.
I
I know. We're short like that's an ad. I already changed it. Like I can't. Like I just can't. Yeah. The sleeves like more working.
At least I'm the only one that's that because I feel like I have like 3 shirts like that. They just drive me crazy. I want them to be right here. They just don't feel like almost like.
Listen, did you hear back from the Williams case? No.
Like this is like a really like a light, but it just comes in folded so easily. Yeah, it's like a very light. I don't even care as long as it's just like here. Like it's thanks mom. You did all of it, right? There's some of it, like there's like 3 of them that never worked online. So remember, like I did all of them, but the issue came with like it says like okay now to complete this exit at the top and then refresh the screen then it should go away. I listed that like 10 times on all 3 of them and it just doesn't go away. It still shows the issue.
As far as the certificate,
Oh, okay.
and
I
mine,
did it. Whatever. So
I emailed the thing
I had like literally built it. I hate talking on the phone so much.
but
No, but you have to
if you go to the city website, it's basically
Oh, you have to so we still don't have our password.
it should work. You know,
Well, I think in my email is my work email. I think it's what I did.
the work email is there, but my login was not my email address. My login was something I created, so I logged in. I was like, yeah, it was through. It was when I was at UVA. They're trying to be a login.
Yeah. Yeah, it's a login that I learned to use. So I'm like, oh gosh,
Yeah, if you try to like do the forgot password that you created,
it's gonna go back to my work email.
right? Which reminds me to change my